summer, so yes, you can cheer, that's all good. Then we'll resume back in September. Other than that, not much else is going on. Everything's pretty status quo. So, this month's Con Ed is going to be on stroke. Yes, we do stroke every single year, and it seems like right around this time frame. We do have to do stroke education specifically for the primary stroke center accreditation. Every single hospital or every resource hospital or any hospital that's a primary or comprehensive must do stroke training for EMS to be able to maintain their accreditation. You guys have been so gracious too over the past years when we have our actual accreditation as far as running some scenarios as far as bringing patients in, so we also appreciate that. So Adam Greenberg put this together along with Captain Steve Jagman, who is the EMS coordinator from Skokie. Yes, Adam is still around. He still teaches for us as an EMS educator status, even though he is the emergency management. But EMS and emergency management, we work pretty closely together. So, yeah, and this month, again, I do apologize, another short one for you. I know you love having me here till noon for 3 hours, but you know, I definitely, we can get you guys the information that you need to know in a pretty timely manner. So if you have questions, please stop, let me know, ask, and I'll answer them to my best of my ability. So we take a look at strokes and how patients actually end up having strokes, but there's a lot of underlying conditions that usually are associated with it. American Heart put out in 2019 the top 10 most common causes of death, and cardiovascular still is, or heart disease is right up there on the top, but stroke has actually moved up to the 5th leading cause of death. Now new is suicide and pneumonia, influenza, diabetes. Those have actually made their way onto the list now. Not a great list to be on. So we take a look at who's having strokes. It doesn't matter male, female, what ethnic group you belong to, but women have a unique sense when it comes to having stroke. There's a lot of other things that can cause a woman to have a stroke. You could take a look at young women who are on birth control and maybe smoke, or even just birth control in general, that can cause blood clots and having a stroke. So a woman who's actually going through the labor process, delivering a baby, may end up having some type of amniotic fluid type stroke. Then you get to the point where an older woman starts to go through menopause and she ends up with hormone replacement therapy, which can lead to blood clots and having strokes. Different groups, ethnic groups we talk about, our African Americans are about 57%, the highest range for women in stroke, whereas Indian or Native Americans are at the lowest at 39%. So, strokes happen very commonly. Once every 40 seconds a person can have a stroke, and we see death occur usually at about 3.5 minutes of someone having a stroke. So most of the deaths do occur outside the hospitals. Now, the impact of a stroke, it's not like other disease. You know, you go ahead and have a heart attack, they go ahead, they put a stent in, they put a balloon, they do bypass surgery, and then you get out of the hospital, you go through cardiac rehab, and you're pretty good. You know, you go back to your everyday living in most cases. But strokes are a little bit different. The long-term impact is pretty great. And I apologize because you probably heard this story over and over again from me, but a very dear friend of mine, his name was John Waukegan, firefighter, and he was fixing a fire truck. Someone thought it'd be funny, turned on the siren, turned his head really quick. He had plaque built up in his carotid arteries. Some of that plaque broke loose and went to the posterior side for stroke, which obviously long-term impact. He walks with a cane. He has long-term, short-term memory, has difficulty swallowing. And so along with that, all that comes depression, because his very active self and, you know, the fishing and the firefighting and losing his career, you know, really took a toll on his mental psyche, if you will. So strokes don't just get better and you walk away from them, there's a lot of long-term impact. A lot of it is depressive signs and symptoms because they can't go back to the life that they lived before. They might have the inability to communicate. They can't eat like they would. You know, they may end up having G-tubes because they can't swallow. They need some assistance, whether it's a walker or a cane, to actually get around. And then, of course, they have memory issues. Years ago, when you guys were, a lot of you were in paramedic school and you were taught about strokes. You were taught the signs and symptoms of a stroke, but that's really where it stopped. It didn't really come down to the different types. This is the signs and symptoms if you have a hemorrhagic or an ischemic stroke. And so when someone was having a stroke, our job was to get them to the hospital, have them have that CT, and we avoided certain medications because we as EMS providers could not know what kind of stroke that patient was having. Thanks to medical technology, we are now taking a look at some of the different signs and symptoms, and we're able to identify, is it a hemorrhagic? Is it ischemic? Is it a large vessel occlusion? Some of you guys may not have heard that term before because that's fairly new. We are now having you guys identify large vessel occlusions. For the most part for you, it doesn't mean a lot. It soon will based on where we're going to take these patients, but we're learning more and more about strokes. There's a cryptogenic type stroke. It's like, what's that? We can do as many tests on a patient, but we may never know what caused that stroke. And that's what we see with that type of stroke. Brainstem strokes are probably the worst strokes of all. These are what we consider the locked-in strokes. These are the ones that people don't move from the neck on down. They're unable to communicate, so they lay there in that vegetative state. And you know, there's different treatments with that. So we start off with our ischemic stroke. Now, most patients are going to have an ischemic stroke. About 87% of all strokes are ischemic strokes. And we as EMS providers, we use the Cincinnati Stroke Scale. Well, let's take the speech, the arms. Do we have facial droop? Those are some of the big signs and symptoms that we see. Knowing that some of these ischemic strokes, mainly the embolic type, can cause a headache. A bad headache, but not as bad as a hemorrhagic stroke. We look at the face. Is their face drooping? You know, we can ask them to smile, you know, we can kind of see the one side of the mouth turned down a little bit. How about holding out the arms? One thing we don't want them doing is doing the equal hand grasps. You know, for years and years, can you grasp my fingers? And we would measure weakness based on how strong they could squeeze our fingers. We fail to remember, though, that some of these patients may have arthritis and may not be able to squeeze, which is why we have them hold their arms out. Talking about speech, it's not just do they slur their words, but do they get the right word? Try to remember that this is a coffee mug. They may not be able to do that. Or they may say something and all their words get jumbled, or it turns into pure gibberish. Now T, as far as the fast going up here, you know, a lot of people have seen, oh, fast. I've kind of modified the T because T is for calling 911. But for us as EMS providers, T should be when did signs and symptoms start? And not only when did signs and symptoms start, but when was the last time that that patient was seen well? That's what we're really looking at because that's very important to determine or help us determine what kind of treatment a patient may have. Now, depending on where the ischemic stroke actually is, we're going to see different things that occur. We may see weakness on just the lower extremities, or it could affect speech or memory. They might stick out their tongue and their tongue deviates to one side. So yeah, like I said, they say 80%. I think these are probably the new updated 2019. I'm still stuck in the 2017s as far as statistics. But when we talk about ischemic strokes, there's different types. We all think of it as a clot, and that's true. But some of it is that vessel may have had some plaque that broke off. So our bodies try to fix it. So platelets go all to that area of the plaque trying to replace it. Red blood cells are running over the top of it, and as those platelets are getting there, the blood cells are getting stuck on it. This is kind of a kindergarten explanation. And as the body goes ahead and fights it, then the coagulation cascade comes in, and we start putting fibrin, which has little strands that make that clot even tighter and more healthy. And that narrows down the vessels, so there might be just a little bit of room for blood to flow through. With that also comes the part that broke off, the emboli, the blood clot from AFib that got dislodged, DVTs, pulmonary emboli or emboli in general from sitting for too long. We see that a lot of times with our ischemic strokes. Now, when an ischemic stroke happens, you can see that general area of infarct. Remember, the term infarct means cell death. It means that those tissues, those cells are not going to come back no matter what we do. So what we're looking for is we're looking for that penumbra, that area on the outside. We're trying to make sure that this area, being ischemic, lack of oxygen, is going to get the oxygen it needs, and we can revive that area. It's not dead yet, so we can hopefully try and fix it. And there's a lot of different ways. Now, Region 11 is doing a pretty good study right now, and some of the slides you'll see will have Chicago's logo on it. I sent that off to Adam because they had some great slides in it. They're identifying large vessel occlusion because they're taking them to more appropriate hospitals rather than just primary stroke centers. And we'll get into that a little bit later where it's appropriate to take a patient. But we can identify a possible large vessel occlusion based on other signs and symptoms that we may be seeing with our patients. So with these patients, we see a lack of blood flow to a certain area. And one of the things we're looking for as signs and symptoms is the gaze. When we see a large vessel occlusion, we're going to add, well, they use GFAST. Do they gaze off to one side? You may ask them to follow your finger, and they may be able to do it, but as soon as you take that finger away, their gaze goes back down to one side. That could indicate a large vessel occlusion. They're still going to have, or may have, face that's asymmetrical, speech that's got slurred, arm drift, okay? Other things we look for is it a posterior? Posteriors a lot of times get missed. Most of the time actually get missed. And remember, in the posterior wall, our cerebellum is responsible for fine motor skills. It's responsible for our balance. And so when we see people that feel like they're being pulled in one direction as they're trying to walk, or there's leaning to one side all the time, might be that it's a posterior circulation type stroke. You might have, because of the way the nerves cross within the brain, you might have numbness on the left side of the face, but the right side of the body might have generalized weakness. Those, again, can indicate that a patient is having a posterior stroke. Now, the remaining is our hemorrhagic strokes. Hemorrhagics are bleed within the brain, mainly two types. We look at a subarachnoid bleed, or we can look at the intracerebral type bleed. Sometimes these can be fixed, sometimes they can't. A neurologist would actually have to take a look at it. Our subarachnoid is right on the surface of that brain. It's basically blood on the brain, where the intracerebral is blood deep down in the brain itself. So what are our signs and symptoms when we talk about the hemorrhagic stroke? Some people will describe it as a thunderclap type headache, or the world's worst headache, sudden onset headache, double vision, blurred vision, light sensitivity to the eyes, projectile vomiting, nausea, vomiting. And yes, they still may have the standard facial droop, arm weakness, slurred speech. They may have trouble seeing in one or both eyes. And like I said, the headache, dizziness, loss of coordination. Now, the first protocol we're going to take a look at here is our hypertensive protocol. To have this protocol go into effect, we're looking at a systolic greater than 220 or a diastolic greater than 120. You don't have to have both. It could be one or the other. But we're looking for other signs and symptoms along with it. Do they have a nosebleed? Are they having neurological deficits? Unequal pupils? Weakness on one side? Breathing issues? And if we go really into it, do we see Cushing's triad? Elevated blood pressure, decreased heart rate, irregular respirations. it's important for you guys, when you have a patient with these high blood pressures, to get as much information and call that into the hospital to help them make the determination. Could this be a hemorrhagic stroke, or is it truly just a hypertensive crisis? What's the patient's history? And always ask yourself, why does this patient have such high blood pressure today? It really helps you ask the right questions. We want to take blood pressure on both arms. Make sure we're not having any type of aneurysm. Whatever, some type of aneurysm. Now, nitroglycerin is a medication that can go ahead and help us reduce blood pressure. But we have to be very cautious. It's not something that when you call in and they don't give it to you, you get all upset. How good did you explain in your report what was going on with the patient? Could that doctor or nurse see what you were seeing based on what you're describing? I'll be honest with you, most of the time they'll probably tell you don't give the nitro. They don't want to risk, if someone is actually having a hemorrhagic stroke, to go ahead and dilate those coronary arteries, cause a bleed to get bigger, or even if it is some other type of stroke, open up those vessels, have the clot go further on down the line. Now, with nitroglycerin, this is just a quick poll from you guys because I've had some things come across my desk. This has nothing to do with the CE, but do you have a preference between tabs or spray for nitro? The reason I'm asking is because I've had some people requesting to switch from tabs to spray. And if that's what the general consensus wants, I'll be happy to go down that road. But I want to make sure it's something y'all want versus just one or two people. Anybody have an opinion?
Gary?
You like the spray?
I'm just saying it works better, it doesn't crumble, it's easier.
It's easier, yeah, and it lasts longer once it's open. I personally too, but I want to make sure everybody has a say before I go in and dictate something. Okay, well, I'll be honest with you, the general consensus has been pretty 50-50 lately, but I'll leave it up to Dr. Lott, but I really want to be able to have some information of what you guys feel before I take him. So, how many of you guys realize that you can give a nitro without an IV established? You have someone with chest pain, and you're getting ready to go ahead and, you gave them the aspirin. You did the vital signs, blood pressures, maybe 157 over 88. You've been taught for so long that you had to have an IV established before you administered that nitro. Remember, we want the 12 lead before you administer the nitro, but we've been talking a lot and there's been a lot of questions and people have been asking, why can't we give that first nitro in the house and then start the IV in the ambulance? You actually can. So just another sidebar that making sure everybody's on board. Now, be careful with blood pressures if they're lower. If it's relative or absolute hypotension, meaning absolute less than 90. Relative, they're normally hypertensive, but today they have a 110 blood pressure. Might want to be a little cautious on something like that. Remember, nitro decreases preload, decreases afterload on our patients. It also decreases the oxygen consumption. So we use it for chest pain patients, pulmonary edema patients, and hypertensive crisis patients. Those are the three main protocols we use them. Don't forget, if you're going to nursing homes, to look for nitro patches or even sometimes nitro paste. Not that I don't know of any of them that use the nitro paste in the nursing homes, but I don't work in the nursing homes around here. So, also make sure you're evaluating for any contradictions, like do they take Viagra, Levitra, Cialis, and it's not just men. We have to ask questions for women. Remember, the Viagra was originally for pulmonary hypertension in women, so we want to make sure that everybody across the board is not taking a medication that go ahead and drop the pressures. TIAs. By definition, TIAs, a lot of people will say are mini strokes, but they're strokes that do not go ahead and have long-lasting effects. They go ahead and resolve themselves within 24 hours, We're not going to go ahead and wait 24 hours to see if they resolve themselves. Obviously, we're going to get them to a hospital fairly quickly. But these are kind of preludes into a bigger stroke. And short-term risk of a stroke after a TIA is about 3 to 10 at 2 days, 9 to 17% at 90 days. So we do see an increase of patients having stroke after they've been having TIAs. How do we know if it's a stroke mimicker? I always like to share my stupidness with you guys that hopefully you learn. I learned a very big lesson pretty early in my career. As most of you know, I live in Burlington, Wisconsin, small community, farming community. We're about about 45 minutes away from Milwaukee. And a lot of our stroke patients, we actually fly up to Milwaukee. And I had been a medic, well, about 6-7 years at the time. And I had a gentleman, and I got there, and I'm like, this guy's having a stroke. I was bound determined he was having a stroke. Called the fire department in, set up a landing zone just down the road a little bit. Man, I was feeling good about myself that I was on top of this. We were going to save this guy's life. And flight came in, took the patient, went up there. Next day, got a call from my medical director. Blood sugar was 28. I forgot to go ahead and check sugar. Guy had a nice big helicopter bill to be discharged later on that day after treatment for hypoglycemia. So, Gary gets paid, yes. But what good did I do for my patient here, you know? I was looking at myself going, are you kidding me? How stupid, and I knew better. But I got that tunnel vision because I was so determined this guy was having a stroke. We have to make sure you're always asking the questions. Why is my patient presenting the way it is today? What is the differential diagnosis? What are all the different things that could be going on? And start whittling away things as based on signs and symptoms that we're seeing or questions that we're asking. You know, are they hypoglycemic? Do they have a stroke history or a seizure history? Do they have migraines? Migraines can mimic a stroke very closely. Are they on drugs or alcohol? You know, do they have some type of trauma? Did someone knock them in the head and they actually have a head bleed? So we want to make sure we're following these as best as we can. One of the other ones is Bell's palsy. Now, Bell's palsy is an infection of the 7th cranial nerve, which affects the face. It basically paralyzes the face itself. And I like this chart better because it kind of compares what we are going to see with Bell's palsy compared to a stroke. But Bell's palsy, you might see facial droop. You might see speech difficulty in these patients. Their eye, they'll have to kind of close it on their own. It's tearing up all the time. But some of the things that you can use to determine Bell's palsy versus a stroke, have them furrow their brow or wrinkle their forehead or lift their eyebrows. If they're having a stroke, both eyebrows will go up. If it's Bell's palsy, the side that's being affected will not move. You know, they're not going to be able to crinkle their forehead or move that eyebrow up. Very simple to go ahead and do. Take a look further. Arm drift, no in Bell's palsy.
EMS Con Ed, 21 engine 21. 6 days at peer services for the 30s, allergic, can't move, and 35 at a time.
Hospital stroke, yeah. Unequal pupils, probably not so much with Bell's palsy, but likely or could be in someone having a stroke. Okay? So again, always ask yourselves, why is this patient presenting the way they are today? Why do they have high blood pressure? Why are they bradycardic? Why do they have this pain? And then say, okay, X, Y, Z are my differential diagnoses. Start taking away from there. All right, pediatric strokes. Yes, peds do have strokes. More commonly with pediatrics, it's going to be a hemorrhagic type stroke versus an ischemic type stroke. Now, Why is that? Well, we see a lot of times with the hemorrhagic ones, there's some type of abnormality within the brain versus the ischemic. The kids maybe just don't have the clotting problems or the past medical history that's associated with it. The other problem with pediatrics and having strokes is we don't expect them to have strokes, so it takes a little bit longer for us to diagnose. And I don't want to say if there's a positive in a child having a stroke. The acute phase is pretty bad, but the long term, they do very well. They recuperate very quickly from if they've had a stroke. So you've been called out to someone with stroke-like symptoms. Got the call. I think someone's having a stroke. First question should be, when did the signs and symptoms start? And not only when the signs and symptoms started, but when did you last see your mom well? Because how do we know all the time? Mom went to bed at 10 o'clock last night. She woke up at 5 o'clock this morning, and now she can't move her left side. Did the stroke start at 11 o'clock or at 4:30, just a little bit before she got up? So finding out that last known well time. And this is important because we have 4.5 hours to get them TPA, which is like our liquid vascular or liquid drain over the vascular system. But if we don't make that time frame, there's other things that we can do for this patient. We can take them to thromboectomy-ready hospitals, and they can actually go in and break up the clot or coil it and pull it out. So I've got some pretty cool videos to show you. Once we do that, check that blood glucose. Remember, the brain needs oxygen and glucose levels are very easy to figure out really quick, and if we can fix it right away, it's a bonus. Ask their past medical history. Do they have a history of AFib? Are they compliant with their medications? Are they taking their meds like they should? Did they skip a couple dosage? Have they been on a plane for a long period sitting there? Do they have a history of DVT? High cholesterol or hyperlipidemia? Those are types of things that could indicate someone might be having a stroke. Perform our Cincinnati stroke scale for our patient. There's a lot of different stroke scales out there. You've got Cincinnati, you've got Los Angeles, you've got Miami. We stick with the most direct and the easiest. I think quite a few. I remember Chicago has moved over to the Los Angeles for this study that they're doing. So they're asking a few more questions. But we're looking for the facial droop, the arm drift, the abnormal speech. This is another assessment. This kind of incorporates that large vessel occlusion that I was talking about earlier. And posterior, what is their balance? Are they leaning to one side? If they get up, do they kind of go to one side, or are they being pulled? Are their eyes gazing to one side? Are their pupils unequal? And of course, face, arms, and speech, and then when did signs and symptoms start? Take a look at their eyes. You know, are they both dilated? Are they reactive, unreactive? Are they on some type of medication that would dilate their pupils? Are they unequal? Do we have herniation starting in that brainstem? Remember, the third cranial nerve is going to be the one that gets affected first, and that's why we see unequal pupils. When they smile, does the face not move on one side? Can they wrinkle their forehead? I'll play a video here for you.
Yes.
Lady Antebellum was the big winner tonight with 5 Grammy Awards. Rapper Eminem, the big shocker, winning only 2 despite 10 nominations. CBS 2's Serene Branson is live from Staples Center with highlights and backstage coverage we're seeing for the very first time. Serene.
Well, a very, very heavy rotation tonight. We had a very Darrison, but let's go ahead, Terrace Chase, and look for the head of the pin.
So, this woman here on live TV, they thought was having a stroke. She started talking, and at first, you know, she didn't understand she was talking gibberish. And then she soon realized that something's not right. Actually, the paramedics, they took her, they assessed her for stroke. What she did end up having was a cluster migraine, which led her to speak like this, but that can happen with a stroke patient. You know, they're trying to say something and it's just a bunch of gibberish. One thing to remember with stroke patients and them communicating with you, we kind of have to have an understanding. It can be very, very difficult for them to communicate. And if you're kind of like, I don't understand you, explain to me. And if you're getting like constantly questioning, they can't communicate, they get agitated. And how many of us have seen stroke patients that start getting agitated, they get worked up, maybe to the point where they actually get a little bit combative. And it's not that they themselves are combative, it's that they're very frustrated that they can't communicate, that you don't understand what's going on. Talk to the patients like they understand you. And then just have a little bit of patience when you're waiting for the answers for them. Take a look at the arm drift. We always have our patients, palms up, have them close their eyes. 10 seconds, not just put your arms up, okay, that's good. Because someone might be able to hold it for 2 seconds there, but at the 4th, 5th, their arm might start to drift off. And we have them close their eyes so that they kind of don't cheat. Oh, my arm's drifting, maybe I'll turn my body and that'll help. You know. Some of the other challenges when we're trying to identify if a stroke is actually occurring is, what is the patient's past medical history? Have they had past strokes in the past where they have weakness? Do they have aphasia, or do they have the inability to communicate? Weakness on one side, arthritis, other past medical history. Do they have vertigo, where they're constantly dizzy? Do they have medications that make their pupils less reactive, pinpoint, dilated? So we need to go ahead and at least dive into some of those in the rationale. One of the other tests that Chicago is doing to help us determine if it's a posterior large vessel occlusion is they're doing the finger to the nose test. Because fine motor skills is what's needed to do that. If a patient tries to do this and they do it slow and they're, kind of, okay, here, that could indicate that it is a posterior or a large vessel occlusion. They don't have that fine motor skill. It's being affected some way. But if it's nice and smooth that they can go ahead all day long, we can assume at that point in time that it's not a posterior stroke. Here's some more numbers here, but I think the big one, every time a person has a stroke, it can add 36 years onto their health life. And even a single second adds 8.7 hours onto their health life. And so strokes can do a number on our bodies. So this is our stroke protocol. We start off with our routine medical care, determine that onset, make sure that gets documented in your report. You'll probably go ahead and tell it in your report to the hospital on the radio. You'll probably even tell the nurse what it is, but it's nice that they can go back and refer back to it and say, what did the paramedics say about the time? And they can take a look so they can know how we should treat this patient. Make sure we're doing a blood glucose. If blood glucose is under 60, treat accordingly. Now, in the back of the protocol book where they list all the different drugs out, one of the things that they point out is that if a patient is having an intracerebral bleed, not to give dextrose D50. I've talked to a couple different doctors about this. I said, what if their sugar is 52? And you think they're having a stroke, but you're not sure, their sugars are low, it could be that. Can I go ahead and give dextrose? Is it going to go ahead and cause tissue necrosis in the brain? Remember where the dextrose has to kind of work its way through the body, and it's not going to come out in full dextrose form at that point. The other thing, as you're pushing the dextrose, instead of clamping off the tubing, you can watch your drip chamber. And it kind of dilutes it a little bit more. You're still giving the same amount, but it's not so concentrated. It reduces the concentration a little bit. Perform your Cincinnati stroke scale. One positive Cincinnati stroke scale means it's a 73% chance someone's having a stroke. Identify. Don't just say, yeah, they had a positive stroke scale. Where? What? Okay? Facial droop. No slurred speech, no arm drift. Or they had arm drift, but no slurred speech. Make sure you're identifying that both to the hospital and in your documentation. If we recognize the patient has neurological deficits, their posturing, unequal pupils, What else do we have up here? Posture, unequal pupils. We might want to consider using our drug-assisted intubation, getting them intubated, and then ventilating appropriate. We're going to ventilate a little bit quicker, about 20 times a minute. Use your end tidal. Keep your end tidal at about 35. Causes enough vasoconstriction, but not so much that it decreases perfusion pressures within the brain. They say here, ventilate 1 breath every 3 to 6 seconds, and ventilate based on your capnography. And it does go down and talks about consider drug-assisted intubation. So, question for you. You've got a patient you assume is having a stroke. It has all the identifiers. How important is it for you to start that IV in the field? What do you think? No, it's not. You know, we keep pushing more and more for you guys to start IVs when it's appropriate. Hemodynamically unstable. You need to give them medication, or they have a likelihood of becoming unstable. Not everybody is getting O2 IV monitor anymore. We are now assessing our patient based on our clinical judgment and providing the treatments that are necessary. You know, it's the same thing with the glucose. You got a stubbed toe and the nurse says, what's the glucose? Don't just do a glucose because the nurse asks you. You can very nicely and politely say, it wasn't indicated for this patient, so I didn't do it. You know, and just let her know there's no indications to have a glucose. But, you know, you can do it in a nice format. But we just don't do things because you think it's expected or whatever. We're treating our patients appropriately now. Yeah, an IV, fluids are not going to be, you know, part of the treatment for you guys pre-hospital. Our big thing is to get them to a hospital as soon as possible. 2 times to load and go. One is a trauma, the next is a stroke. Time is the essence for the brain. We want to make sure we're getting them the appropriate treatment. The other thing is, if we make them into pin cushions because we're not either very good with our IVs or they're a difficult stick, if they do qualify for TPA, they're going to bleed from every place that we poke them. Now, those can be a little bit easier to go ahead and control, but it's not something that is a definite necessity. We don't want to sit on scene and start that IV. Same thing with a 12 lead. A 12 lead would be very beneficial with the patient having a stroke. It's a great thing to know. Do they have AFib? Are we sure that it's not an MI that's occurring? But to sit on scene and do all of this stuff before we get them to the hospital, we need to get them to the hospital. We need to get them to the more appropriate place. This is our drug-assisted intubation protocol. If we suspect increased ICP, we administer lidocaine, 1.5 milligrams per kilo. To be very honest with you, again, this is another major topic because there's really no documentation for or against the reduction in ICP with lidocaine. I said last time I would be surprised if it was left in, and it got left in, so we'll see what happens this next time around. Remember with your etomidate, if you're getting ready to intubate a patient, you're using this protocol, have everything ready. Get all of your intubation equipment, get the person who's going to intubate all set to go. The person who's going to push medication should have the etomidate drawn up and the Versed drawn up. Have the stethoscope ready. Patient goes ahead or the partner pushes the etomidate, give it a few seconds, do the intubation. Once it's verified tube placement, with your end tidal, listening to lung sounds, go ahead and push the Versed right away. Keep the patient down. We don't need them bucking the tube or waking up or fighting us or anything like that. So yeah, go ahead and use your Versed. This is just what is out there for community education. You guys we've talked about be fast and fast. Faster is another way. They use the E for eyes and the R for reaction time, meaning to call 911. So, where do we take these patients? Once we determine that they're having a stroke, where do they go? So, we have in Illinois stroke-ready hospitals, hospitals that can identify a stroke. We have hospitals that are primary stroke centers, which can identify and start basic treatments for strokes. And then we have our comprehensive, which usually have an interventional radiologist on staff. They're thrombectomy capable, meaning they can coil or break up that clot. So all the hospitals have something a little bit different. Nice little chart here talks about the difference between stroke ready, primary, and comprehensive. Back in 2012, Illinois passed a law that stated if we identify a stroke, we are to bypass any hospital to go to a primary or a comprehensive stroke center. So what hospitals are those? Well, Region 10 is probably one of the very few regions in Illinois that really doesn't have a stroke protocol like that, because all of our hospitals in Region 10 are primary stroke centers. You can see by the list over here on this side, the ones with a double asterisk are St. Francis hospitals. The rest of them are like Lake Forest Region 10. These are all they're all a stroke center. And so we take a patient and we go to the closest stroke center of a hospital. Now, comprehensive stroke centers, Lutheran General, trying to think what else is fairly close to you guys here. We've got Rush and Northwestern, Loyola, Resurrection. So these hospitals have interventional radiologists on staff 24/7. They can do more of an interventional type treatment. With the TPA, we say less than 4.5 hours if from signs and symptoms started. With these, we can go up to 12 hours, I believe it is. Could be longer, I just drawing a blank here right now. In Illinois, we have 2 services that actually have stroke ambulances. These ambulances are out of Northwestern and out of Rush. They actually have a CT scanner right in there. When the fire departments are dispatched for a possible stroke, these ambulances roll with them. They're staffed with a paramedic driver, a critical care paramedic, a nurse, critical care nurse, and a CT technologist, and then they have telemed. So once everything's done, the CT goes to a neurologist, they identify, and then they can go ahead and start early treatment if necessary. So these are some stats from Central DuPage. They've been doing it for about 14 months, 8 to 8, 700 days, or 7 days a week, 365 days. I'm having my own stroke here. They've done 450 stroke calls over those 14 months, and they have currently reduced their TPA delivery time from 82 minutes down to 52 minutes. That's a half hour. A lot of people think, well, is a half hour a benefit for the money that it's costing for that stroke mobile? So we'll kind of see what more and further statistics show. They're trying to get their goal under 40 minutes for TPA. So as I was telling you before, there's other treatments out there other than TPA that can go ahead and be used. TPA, yeah, the 3 to 4.5 hour window. Intra-arterial thrombolysis, which is where they can go in, they can break up the clot, they can coil it and bring it out. Yeah, this one's up to 6 hours. Thrombectomies can be up to 8 or 12 hours to read. So let's take a look here first a little bit at TPA.
Activase, also known as recombinant tissue plasminogen activator, or TPA, is the only drug approved by the FDA for treatment of stroke. Growing plaque can rupture, promoting thrombus formation by activating the coagulation cascade. Platelets and red blood cells aggregate at the site of injury, causing further narrowing of the artery. This impedes blood flow even more and causes turbulence in the artery. It also increases the likelihood of thrombus formation. As the thrombus grows, it causes increased vessel narrowing, leading to partial or even complete occlusion. The occluded artery leads to ischemia and tissue necrosis. When a piece of thrombus breaks off, it's called an embolus as it travels up the artery. During a stroke, ischemia can progress to infarction. Beyond the infarction lies still viable tissue called the penumbra. Cells within the penumbra are potentially salvageable if blood flow and vital oxygen are restored promptly. The penumbra is the focus of fibrinolytic treatment. Now let's look at the thrombus itself. Inside the thrombus are strands of fibrin, the protein that forms a clot. Enmeshed within the fibrin is plasminogen, the inactive precursor of plasmin. Activase is administered by IV infusion within 3 hours of acute ischemic stroke symptom onset. Activase binds to the fibrin in a thrombus and converts plasminogen to plasmin. Plasmin then breaks the strands of fibrin and dissolves the clot. As the clot dissolves, blood flow is restored, and viable tissue may be reperfused. Although the original infarction remains, when surrounding cells in the penumbra are saved or reperfused, function may be restored. Activase, the 1 TPA for stroke, is the
Okay. Let's look at this one. So with this one here, they enter either the femoral artery or they can go through the radial artery. And they have a sheath in place. This one brings a little separator, which is actually going to break up the clot. They turn on an aspirator, which then will basically suck the clot into the sheath that they have there in place, so as a way to remove this clot. Kind of vacuums it out of the way a little bit. And they bring the separator in, and then anything else there, they're able to kind of suck it in, vacuum it up, and then they're able to retract the sheath. You turn off the aspirator and blood flow is then restored. And then the last one here is coiling. Dr. Huja out of St. Luke's actually had a part in the therapy, or the study of coiling a clot out. So again, a wire is put into place with the sheath. The wire comes out and it kind of comes out in a coil format, which then wraps itself around the clot. Again, they put up a balloon to make sure that no extra pieces go floating any further downstream. And here, they're actually just going to go ahead and retract the clot and pull it out. And they pull it right into the sheath there. So those are just some of the different ways that we can actually go ahead and help people that have had a clot. Now, we talked a little bit about different hospitals and all the hospitals being primary stroke facilities. The reality of it is that if you have a patient who has maybe a large vessel occlusion, keep my job here after I'm done saying this, Evanston is not a comprehensive stroke center, nor do they go ahead and have the certification to be a comprehensive stroke center. But what they're working on is a different type of certification, which is a thrombectomy-ready stroke center. If you suspect a patient is having a large vessel occlusion, maybe, you know, posterior, they can't touch their eye gazes that we kind of talked about. The reality of it is, God bless me here, Evanston is going to be probably the better hospital to take the patient to. You know, it's all about the patients, and that's really where it comes down to. We at St. Francis don't have thrombectomy capable hospitals. Yeah, it's like, if Adam's back next month teaching, you'll know why. So,
Drinking a Kool-Aid, Mike.
yeah. But no, really, I mean, we're doing this for our patients and having them taken to a more appropriate hospital. I mean, if it was my family members and you guys were transporting and you knew it was a large vessel occlusion or highly suspected, and they had thrombectomy capable at one hospital and not at another one, you know, I would appreciate you taking me over there versus at the other place. But you know, we partner with Resurrection, we partner with Rush. We are very good. We work with Superior at our facility. If we identify a stroke, obviously we can do the TPA right away, and some of the other things that may be based on our neurologist experience. But some of them, they may end up being transported to these thrombectomy. And actually, some of our patients are going to be being transferred to Evanston Hospital. We just found this out probably about 2 weeks ago, because they do have that thrombectomy capable treatment for them. So, all right, what happens after a stroke? Well, we talked about before about all the different things that could go wrong, you know, but the big one is, do they understand their discharge instructions? Are they able to stay up and become compliant with their new their new plan, their medication plans, their medical plan? What are they supposed to do? Are they supposed to go to therapy? Do they have a support group? You know, there's a lot of other things that are going to affect these patients besides the stroke, and it's the past history that they've had. Did they have AFib? Do they have high blood pressure, hyperlipidemia, where they have high cholesterol? Are they very prone to depression? Most of the patients that end up having a stroke go home with many different medications. Antiplatelets, you know, like Plavix, or anticoagulants, not only Coumadin, but Eliquis, Pradaxa, you know, some of the other ones that. They get an antidepressant, and yes, they automatically give these patients this if they're not already on it, because chronic conditions can be very wearing on someone's mental health. And then obviously we want to keep blood pressure in check and cholesterol under wraps. So they're going to go home with a lot of different medications. So it can be, you know, one of those conditions where can they afford all those medications? Do we have to find a way to help them? Do some of these companies here have benefits for these patients to get their medications cheaper? You know, do they understand when they're supposed to take these? And that's going to be the biggest thing with a patient being compliant. Do they really understand their discharge instructions, their medication instructions? Which I truly believe, you know, those that are doing mobile integrated health, and you guys are starting, sounds like we're kind of on the upward slide. We're doing good things right now with it. But, you know, these might be somewhere down the road, another type of patient we can add into it just to make sure that they are being compliant, that they don't end up having another stroke. So, anybody have any questions? See? All right then, I will give you the quiz.